Welcome to the JOMA podcast, presented by the Jewish Orthodox Women's Medical Association. Every week, hear from expert medical professionals as they share up-to-date insights on health topics to help you live your best life physically, mentally, and emotionally. Join us as we navigate the ever-changing landscape of healthcare and strive to improve the health of the Orthodox Jewish community.
Welcome to the JOMA podcast. I'm your host, Jennie Berkovich, pediatrician and director of education for JOMA. Today's guest is Dr. Natalie Zelenko, a breast radiologist, and we had a really honest and important conversation about the importance of screening for breast cancer. With over 15 years of experience in the field of breast imaging, Dr. Zelenko is a skilled and compassionate physician dedicating to providing exceptional care for her patients. She specializes in high-risk breast cancer screening and breast cancer diagnosis, utilizing multimodality imaging and advanced breast intervention techniques to offer a comprehensive approach to regular surveillance and early detection. Dr. Zelenko's expertise spans a range of breast imaging modalities, including mammography, digital tomosynthesis, ultrasound, breast MRI, and minimally invasive image-guided biopsy techniques, allowing her to provide tailored, evidence-based care for each patient. Dr. Zelenko received her medical degree from Cornell University Medical College and completed her residency in diagnostic radiology, as well as a fellowship in breast imaging at Maimonides Medical Center. She's board certified in diagnostic radiology and is a fellow of the American College of Radiology, maintaining memberships in the Radiologic Society of North America, Society of Breast Imaging, and European Society of Radiology. Dr. Zelenko is dedicated in staying at the forefront of her field, attending numerous leading medical conferences in the United States and abroad. She's committed to continued learning, ensuring that her patients receive the most advanced and up-to-date care possible. Hi, Dr. Zelenko. Welcome.
Hi, thank you for having me.
This episode or this conversation is actually very relevant to me. I just went and had my annual checkup, and let's just say that I am around the age where we start having conversations about routine screenings for cancers, for malignancies. And I actually just asked my PCP, like, hey, is it time for mammograms? How do I know that it's time for mammograms? So maybe let's start there. Like, what are the current recommendations for when women need to begin routine mammograms, and how do those recommendations change or vary based on people's situations?
Okay, so that's obviously an excellent first question. I'm not going to ask you how old you are, but the current recommendations are as follows.
Mm-hmm.
And they're a little bit changed from maybe what we were used to hearing about 5 to 10 years ago. Okay, so the current recommendations are as follows. A baseline mammogram, so that's the first one you get, somewhere between the ages of 35 to 40, right? And then an annual mammogram, that's once a year, starting at age 40 for women who have no additional risk factors. So patients the population that's an average risk. So these are women who don't have a family history of breast cancer, who themselves don't have knowledge of a genetic mutation. Average risk factors, your average, I would say, Western European/American women of average risk. The previous recommendations did not, interestingly, include this one baseline mammogram between 35 and 40. We used to say you start at 40 and you go once a year after 40. But the updated recommendations have included this one baseline between 35 and 40. So most women kind of go at around 37. As a personal anecdote, I started at 35. I really do think that makes sense. So these are the current guidelines. Now, if you're going to ask me what happens to women who have an elevated risk, right? Women who have, let's say, family history of breast cancer. So then we have to talk a little bit about what kind of family history they have. If it's their grandmother who had breast cancer at the age of 85, that doesn't really change anything. And you'll hear in a second why. Now, if it's a first-degree relative, so that would be a mother or a sister, okay, who had breast cancer at a relatively young age. So let's say, for example, age 42, okay? So then we say we start screening 10 years before this first-degree relative was diagnosed. So if, for example, a person's mother or sister was diagnosed at age 42, we would start screening them at age 32, okay? It gets a little bit more tricky if it's younger than that, because typically we try not to start mammography in patients who are younger than age, let's say 30 approximately, just because it is a little bit of radiation, and that radiation is cumulative over time, right? Or cumulative over the course of your life. We do it. We definitely do it if there's an indication, but we try not to make it an annual thing. So let's say, for example, in those somewhat rare cases where a person's first degree relative, so again, a mother or a sister, was diagnosed at, let's say, age 35. So 10 years before that would be 25, right? So that's pretty young to start annual mammography, right? Not just the one, but also get one every year. It's a bit young. So in those patients, we really recommend screening with breast MRI until they are about 32-ish approximately. But, those conversations can get a little bit complicated. So I would say we can definitely explore it here. But if there's someone who fits into that category, then that's, I think, a discussion they really should have with their healthcare provider, and probably also with a genetic counselor.
So you mentioned the exposure to radiation. So I think that's important to address. I find that many people, when they hear that for any kind of diagnostic test, they go, "Oh, well, why do I need that?" Certainly if like I feel good, I don't feel any masses, I don't have any risk factors, why would I expose myself to radiation for this like baseline mammograph, let alone like an annual one that I need after turning 40? How do you approach that risk benefit conversation?
Sure. Another excellent question. And a question that I get quite often, and patients, we generally have this fear of radiation, which is not entirely unwarranted, but I think it's important to discuss what is radiation, what is the dose for the exam you're talking about, and how does that relate to other radiation exposures we have in our life. So, and I think that this is an area where a lot of people are just not knowledgeable, and that's okay. But for example, when radiation is all around us, right? There's background radiation everywhere in the world. Sometimes in certain places where we are on Earth, we get exposed to it more. In some other places, a little bit less. But for example, there's background radiation in the atmosphere. So when you fly in an airplane, you are exposed to what I would say, some radiation, right? And it's not negligible because it's more than what you're exposed to when you're on the ground. So, I mean, we can get into doses, but I think that that's a little bit more detailed than most people want to know. But just for reference, for example, if you fly to Israel and back on a transatlantic flight, and it's a long flight, so the radiation exposure cumulative over that return flight, back and forth, is just a little bit less than the exposure of a mammogram.
Wow.
Yeah. And I think when you're able to think of it that way, then that really changes things, right? Because the dose for a single mammogram or a chest X-ray is really minimal. Now, if you're getting a CAT scan, every 6 months, then that's probably a significantly more substantial dose. But, if for any screening test, we always, as a medical community, we weigh benefits versus risk. And the radiation risk of even an annual mammogram once a year, starting at age 40 until, God willing, you live till you're, I don't know, 85, 90. So again, the risk is, the dose is so low that the benefit significantly outweighs the risk. And let me just go back to something you mentioned. People say, I don't feel a lump, I don't need to get a mammogram, right? So this concept of feeling a lump, I think, is a little bit misleading, right? Because of course, if you do feel a lump, then of course we want you to come in for imaging, right? But if, God forbid, for example, this lump is a cancer, then we don't want to find it when you can feel it, right? That's not when we want to find it. The whole reason we do this, the whole reason why we do mammography as a screening tool, is because we want to find it way before you feel it, way before you could possibly feel it, right? The goal of a screening mammogram is to find cancers that are less than 1 centimeter in size. So I'm not American born. For me, that's a normal measurement. But I guess if you function in inches, that's about, we want to find something that's less than 1/3 of an inch, approximately, right? And there is no way that you're going to feel something that's that size in your breast. I mean, is it possible? Yes, but what are the chances, really? Especially if it's not right under the skin, if it's deeper, which is most of the time what happens. So, that's the goal of our screening. And so feeling a lump is just in a completely different category.
I think that's really helpful context. How good or how accurate is mammogram in detecting early stage malignancy like the one that you described?
Of course. So mammography, it a little bit depends on the patient population. Okay, on average, your average Western woman. So again, we're talking about Western Europe and the United States. Mammography is about, I would say, 85% effective alone.
Okay.
Okay. So that mammography alone will miss approximately 10 to 15% of cancers. We know that. We know that going into this situation, right? But and it sounds scary because 10% is a lot, right? But actually, for a screening tool, being able to detect 85% of cancers, even being able to detect 80% of cancers,
Pretty
it's a
good.
very
Yeah.
significant number. It's a very good number. There aren't that many screening tools that we have for other cancers that can get even close to that. So it happens to be a very good tool. Now, when you combine it with an ultrasound, because there are instances, and we can talk about it in a second, where we know mammography is less effective, right? So when you combine that with an ultrasound, those numbers go up a bit, and so then we get closer to 90% if you combine mammography and ultrasound together, which again, those numbers are fantastic. Yep.
So, okay, so then let's talk about that. When do we use just mammography alone versus add the ultrasound?
Okay. So mammography as a tool is it's an X-ray tool, right? We already said it uses radiation, and X-ray, what it does is it differentiates between density, right? So if you're X-raying, I don't know, the chest, then the ribs, the bones are more dense, and the air in the lungs is less dense, and you can see the contrast between them, etc. Mammography works based on the same principle. So the tissue that is more dense is going to look more white, and the tissue that is less dense is going to look more black. And then there's shades of gray in between, right? Depending on how dense and how much density you have in your breast and how much fatty elements you have in your breast. Most people kind of fall in the in-between category, right? So they have I don't know, a 50-50 approximately, right, of
Okay.
dense and fatty tissue. And that is genetic. You cannot change how dense your breast tissue is. Okay. Either you're born with dense tissue or you're born with more fatty breast tissue, and it's genetic. Okay. Sometimes people say, I share this all the time, that breast density gets less with age. That's true. You do lose a little bit of density with age, and you gain a little bit more fatty elements in your breast with age. But if you started off genetically as having dense breasts, you're not going to be fatty by the time you're 90. That's just not going to happen. You're still going to have kind of heterogeneously dense breast tissue. Okay. And the reason this is important is because the more dense the breast tissue is, the less effective the mammogram. And I'm going to explain this concept like this. Imagine if you're looking for a snowball, okay, and you're looking for it on a snow mountain, right? It's very hard to see because there is no contrast. It's going to be a small white ball against the backdrop of a big white mountain. It's very hard to spot. Now, imagine then that you have the snowball, but now you're looking for it on a grassy mountain in the spring, right? I don't know, in the hilltops of Switzerland, for example, right? And so that's very easy to spot because it's going to be, even if it's small, but it's white and the background is green, right? So it's a very easy process to find it. So, I mean, I'm simplifying by quite a bit, but that's the general idea. The more dense the tissue is, the easier it is for a tumor to hide in that dense tissue. And so in patients in whom the tissue is just genetically dense, that's when we would like to use ultrasound as an additional tool, because ultrasound uses not density, but it uses the property of the tissue that reflects light in different way, hence the name ultrasound. And it's just the physics of it are different. And it allows us to pick up additional cancers that we would miss on mammography in dense breast tissue. We know the statistically.
Who makes that call that like, yes, we need to add ultrasound? Is it the PCP? Is it whoever did the exam? Is it the like somebody like yourself, right? Whoever's going to be reading the mammography and like, oh, wait a minute, too dense. I need ultrasound. How does somebody know which category they fall in?
Right, right. So this is a little bit tricky, I'm going to be honest.
Hmm.
One of the reasons is because in this country, we don't have we have screening recommendations from, let's say, for example, the American Cancer Society or the American College of Radiology or the American College of Obstetrics and Gynecology, but we don't have government-based screening recommendations, unlike, for example, in some of the European countries and Israel, where the screening recommendations come from the government. Now, that in and of itself, it has positives and negatives as well, okay, which we can also discuss separately. But here, it is mostly at the discretion of the radiologist.
Okay.
So let's say if I'm reading a mammogram and I see that the breast tissue is dense and the referring physician has not ordered an ultrasound to go with the mammogram, I will put at the bottom of my report, the mammogram appears normal. However, the patient has dense breast tissue and therefore consider adding an ultrasound as an additional study for detecting cancers in this patient, right? Again, the way we practice medicine in this country is that the test is ordered by the referring physician, right? So if there is no referral for an ultrasound, the patient isn't going to be scheduled for that study, right? But okay, and then I'm going to just add one more thing. We had a law that was added in this country in the early 2000s, okay? And the law is that every woman is entitled to know the breast density of her breast tissue, okay? So when you go for your mammogram, and you then your doctor gets the report, the radiologist report, gets a report from me with the details and the medical terminology and so on and so forth. But as a patient, you get a letter that says, thank you very much, you came in for a mammogram, your results were normal, for example, right? And your breast tissue is dense, heterogeneously dense, fatty, whatever. And the reason we have that law is because there was a bit of a discussion about this addition of ultrasound, right? And who should be adding the ultrasound to their mammogram and who shouldn't. And obviously, what I'm getting to is that if your breast tissue is fatty, right, then the role for the ultrasound is really very minimal. Most cancers don't hide as much in fatty tissue. It's very easy to spot. The utility of adding an ultrasound is minimal. Okay, as opposed to if your breast tissue is heterogeneously dense or very dense, then there is a significant utility to adding an ultrasound. And if you want to be proactive, then even if your doctor doesn't order it, but your layman's mammogram report says your breast tissue is dense, then you probably should ask your doctor for a referral for an ultrasound in addition to the mammogram. It gets a little bit more complicated because there are issues with insurance coverage for this test. But again, you do the best you can. I think as a patient, as a woman who's proactive about her health, you do the best you can. You get the referral, you try to get your insurance to cover it. Most of them do, to be honest, most of them do. So, but that's just something that I think if you don't know, you just wouldn't know. And look, it is an additional test. You have to put in additional time to having it done, et cetera, et cetera. It could be at the same appointment as a mammogram. It could be as a separate appointment. So you come in and
But no radiation. I just want to recognize these things,
yes.
right? No radiation. It's not painful, right? A lot of people likely have had ultrasounds, and so it's probably from a risk benefit standpoint, definitely right, worth being aware of.
100%. There is no risk to ultrasound. There's no radiation. And I think the most annoying part of it is that they use gel and the gel is sticky. So,
Right.
Right.
How does MRI fit into this conversation?
Okay, so this is where it gets, well, I guess not that complicated. So MRI is a fantastic imaging modality, right? We know we use it for a lot of things. So breast MRI is, well, I used to say it's a new technique, but it no longer is new. We've been using it for about 20 years. So it's not that new. There are a lot of studies. We know a lot of information, a lot of data that is available. So it is a very sensitive screening modality for breast cancer, which means that it will pick up a lot of things. It will pick up most cancers. Really, it is better. We know it is better than mammography. Its sensitivity, which means its ability to pick up an abnormality, is close to 95%, even probably a little bit higher, especially if it's read by an experienced breast imager. So it's a very sensitive study. The problem with MRI is twofold. Number one, it's an expensive test. So coverage, paying out of pocket is out of the
Yeah.
question. I think for most people, coverage by insurance is a little bit tricky because it's so expensive. We don't use it as a screening tool in the general population because it is both expensive, time consuming, and most patients don't necessarily benefit if they are at an average risk and their breast tissue is not particularly dense. Okay, so again, we're going back to the density, right? Because every time we're dealing with a situation where mammography is more limited, that's where additional imaging with ultrasound and MRI can play a role to help us bump up that detection, right? Higher up. It's like an additional tool that we have in our arsenal. So currently, the recommendations in this country is that we use MRI in patients who are high risk. Okay, and I'm going to explain in a second what that means. High risk as an additional tool to mammography, not instead of. Okay, and this is an important point, because despite the amazingness of MRI and how much I like it, there are certain types of abnormalities that are indicative of cancer that the MRI will not pick up, but the mammogram will. So you never want to use the MRI instead of, but you do want to use it in addition to, for patients who are high risk. So again, high risk patients who have significant family history of breast cancer in first or second degree relatives, especially at a younger age, so premenopausal, right? If a sister, mother, maternal aunt, grandmother, maternal grandmother had premenopausal breast cancer, so that's a significant increase in risk. Paternal grandmothers and postmenopausal breast cancer history is less of a risk, okay? I hope that's clear. If not, we can go back. And then patients who themselves have had breast cancer in the past, let's say 2 years ago, 5 years ago, they've had breast cancer, we really prefer using an MRI to screen in addition to mammography, right? Because we know that we already know they're at increased risk, even if they don't have family history, because they themselves have had cancer, okay? Patients who we know carry a genetic mutation. So mutations like the BRCA 1 and 2 genes that check 2 mutations that elevate your risk for breast and ovarian cancer. So, patients with, we used to say, in the previous years, patients with very significant radiation exposure. So patients who were treated for lymphoma many years ago with a lot of chest radiation, those cases aren't really, we don't have a lot of them anymore. So that's kind of a little bit. So these are the high risk patients for whom breast MRI plays a very significant role, and it is an excellent tool to really increase that sensitivity that those 10 to 15% that mammography is missing.
That's very helpful. I want to wrap up by talking about what happens when somebody gets the call that nobody wants to get, right? They went in for a screening mammogram and you get a call back saying it's abnormal. What can we expect to happen afterwards?
Okay. So first of all, that is not a reason to panic, okay? Especially when you go in for your first mammogram, because a lot of what I do, a lot of interpreting mammograms are comparing old to new, right? And looking for very subtle change, because again, if you remember what I said in the beginning, we're looking for very small tumors, right? So, but if a patient is coming in for their first mammogram, there is no old, so there's nothing for me to compare it with. So anything on their mammogram, any question is a question, right? Because I don't know what it looked like before. And so if it's your first mammogram and you get called back for additional views, I really would not panic, because most likely it's just to clear up. Because again, mammography is a 2-dimensional technique, right? We're imaging a 2-dimensional structure, that's the 3-dimensional structure, the breast, in a 2-dimensional way, right? Because it's a 2-dimensional image. And so structures overlap, things can, look like it's something, but in reality, it's just an overlap of tissue. Or you could have benign findings in the breast, benign calcifications, cysts, benign masses that we just want to get more detailed views and make sure that none of this is a problem, and then we let the patient go, okay? So we use additional mammographic pictures, so sometimes a more detailed coned-in view of a specific area, magnification views, and then we also use ultrasound a lot to help us figure out what's hiding on that mammogram, okay? So anytime you're called back from a screening mammogram, you're going to have extra mammographic pictures, and then you most likely, not always, but most likely will have an ultrasound. depending on the situation. And that obviously is at the discretion of the radiologist who's interpreting the images, okay? If it's not your first mammogram, if you've been going for the last 5 years and now all of a sudden you're getting a call back. So again, I really don't think that anyone should panic. It could just mean that there was a question, again, of tissue overlapping in a particular way. The picture was taken at a slightly different angle and something looks a little bit different than it did before. And we want to get extra pictures to make sure that it clears up. Okay, this is a very common scenario, I would say out of, let's say, like a batch of mammograms that we read, about 10 to 15% get called back for extra pictures, and those numbers are considered normal. Okay, that's a standard, we call it a recall rate, and those are kind of normal recall rates. That's what happens across the country. So again, I wouldn't panic if that happens. And again, sometimes there is a real finding, not just tissue overlap, but there's a real finding, something that we see that's a mass, but that mass may very well prove to be benign. But in order to figure that out, you have to go in for the extra pictures and you have to have those extra studies to figure that out. And then the radiologist will tell you, look, it's fine. It's just a cyst. You can go home and come back in a year. And that is overwhelmingly the majority of the cases.
That's really reassuring, but also I think reinforces the fact that these screening tests are important, and it's important to understand when they need to begin based on your risk factors. I ask this question, the following question, my last question, at almost every guest, and I'm curious what your answer is. If there is one thing or like one pearl that you wish the general population would know to, I generally say to like avoid being your patient, but obviously we don't necessarily want to avoid screening mammograms, but like any one thing that you wish people would know that you could kind of like shout from the rooftops, what would it be?
Okay, I think what I would want everyone to know about mammography in general, and specifically about screening mammography, because in case you couldn't tell, this is a topic that's very passionate, that I'm very passionate about. This is the thing. The reason that we have screening mammography and the reason that it's so important is because it is a very effective tool to find cancers. And here's the really important part. Early breast cancer is extremely treatable, right? So when you find these tiny tumors that are less than a centimeter, okay, or tumors that are not even invasive tumors, but they're what we call in situ tumors that are still kind of sitting in the ducts, really early cancers, what we call, stage 0, those cancers have a cure rate of over 90%, right? So this is why it's so important, because if you have a screening tool that's a great screening tool, but the cancer is not treatable, okay, well, then there's no utility to the screening tool, because it's very nice that you found it, but you can't really do much about it, right? Because you can't really do much about, there's not much available in terms of treatment. Or let's say, for example, you have a situation where there's plenty of treatment for the disease, but we don't have a good way of screening for it, right? We don't have a good blood test or a good imaging tool. So that's also a little bit, useless. But with mammography, with breast cancer, we have both. This is why it's such an amazing situation, I think, for most women, is that it is both a very effective screening tool and it is a disease that's extraordinarily treatable with a really high cure rate. So most of my patients, even when they get diagnosed with breast cancer, they do really, really well. And this is why it's so important. It's important to get this done, and it's important to have it done every year, because this is what we're looking for. We're looking for cancers that are extremely treatable, small, extremely treatable cancers. This is why you don't want to miss this opportunity, because you would really be jeopardizing your health.
So it's a really, really important perspective, and I appreciate your framing it that way. Dr. Zelenko, I want to thank you so much for your time and this amazing conversation. It's been very informative, and thank you for the amazing work that you are doing.
Sure. Thank you for the opportunity to speak to you and your listeners, and it's been fun. Thank you.
Thank you for listening to the JOMA podcast. We welcome your feedback and ideas for future episodes. Send us an email at health@joma.org. Don't forget to subscribe, rate, and review us on your favorite podcast platform.